So I'm so grateful to have this opportunity to introduce myself to the group. And this is sort of who am I, how can I provide service to your physicians and patients, and what exactly does an oculoplastic surgeon do? So I'm going to be super, super brief. So these are my financial disclosures in general. So how does one get to be an ophthalmic plastic surgeon? It's through ophthalmology. So I'm a board certified ophthalmologist. I went to Duke for college, went to Jefferson Medical College. I did an ophthalmology residency at Wills Eye Hospital in Philly. I did a neuro-ophthalmology fellowship at Johns Hopkins, and then an ophthalmic plastic surgery fellowship here in Boston. And I'm the director of ophthalmic plastic surgery at Mass Eye and Ear. I'm on staff at pretty much all the Harvard hospitals, including BI and Children's, so I can consult there if there are patients in need. I'm an HMS associate professor, and in my free time, I'm the editor-in-chief of a journal called Orbit, which I'm sure none of you read routinely. So my history with your group actually dates back a long time ago. So when Helen Rainham first started her career at AP Derm, which probably goes back almost 2 decades, she had sent a flyer around. I was looking for a Mohs surgeon for my suburban offices. And so we started sharing eyelid cancer patients. And then when Helen began seeing patients in her own office, I started joining her 1 day a week. So this even predates Chris Hayes, which seems like Helen and Chris have been together forever. But so I was there a little before Chris joined. And so now work second and fourth Wednesdays in the Natick office. So what do I see and take care of? So I deal with all diseases of the eyelid, orbit, lacrimal system, and some cosmetic things. I take care of patients of all ages, including pediatric patients. And so break it down very quickly into the different areas. So eyelid, common things I do with eyelids: blepharoplasties, ptosis repair, lower lid ectropion and entropion repairs, post-Mohs reconstructions. I take care of a lot of lesions on eyelids, benign and malignant. I do Botox injection for eyelid spasms. Basically anything that's wrong with the eyelids, I am happy to manage. Just a couple patient pictures. This is an upper blepharoplasty before and after. You can see she just has a little less skin on the upper lids, a little better crease and platform. Here is a child with a congenital left upper lid ptosis before and after surgery. This is a patient with malar descent and ectropion of lower lids. It was before and after. This is a patient with a defect in the lower lid after a Mohs procedure. And this is the step-by-step of a Hughes tarsoconjunctival flap and a full thickness skin graft. I love to do post-Mohs reconstruction, so very happy to see any of these patients. Here's a large defect that Chris or Helen made. And that was a bilobed rotational flap and an advancement flap. So lots of creative options. I enjoy this so much that I actually wrote a book on it, which we can get for your shelf if you want some ideas. For lacrimal, I do, again, anything lacrimal, congenital obstructions, adults with tearing, canalicular obstructions. Cosmetically, I do upper and lower blepharoplasties. I do Botox and facial fillers. Not looking to do a ton of them. If you have patients that need them, I'm happy to do them, but I'm more of a pre-op, post-op kind of office, but again, happy to do those procedures if needed. This is a lower lid internal blepharoplasty patient, so just a lot less puffy. Sorry, that after picture is a little unfocused. Here's another patient who had a lower lid blepharoplasty. Here's a patient who had a ptosis repair of the upper lids and a forelid blepharoplasty. My real passion is orbital disease. So I take care of patients with orbital tumors, thyroid eye disease, orbital fractures and trauma, orbital vascular malformations, and ophthalmic sockets. And this, I just want to share one little more in-depth patient, and this is the last thing I have, so I'll try to keep it on time. This is a lady with an obvious orbital mass. You can see on her scan that there's a mass filling the left orbit. She's from out of state, and it was starting to press her optic nerve and cause optic neuropathy. Her local doctors had recommended a craniotomy approach, for this, which is fairly typical for a big orbital mass that extends posteriorly, but she didn't really want a shave and a haircut and a stay in the ICU. So she traveled around the country looking for other options. So we have a Center for Orbital Disease. I work closely with Ben Blyer, who is the other surgeon in this video. So we like to take these out through the nose. It's a lot less morbidity for patients. So there's a review of the scans. This is a highly edited little video, which I will show you. So this was previously biopsied and was a solitary fibrous tumor. So these are a little sticky, but not crazy sticky. So here we've taken down the ethmoid sinuses, we've taken down the lamina that separates the orbit from the ethmoid sinus. So we're opening, the orbit is full of fat. That's the medial rectus muscle, that fleshy thing that we're seeing there. So what's cool about this is we have an endoscope up the nose, but we have 2 surgeons with instruments up the nose. So this is multi-person, multi-handed orbital surgery. So we're going to bluntly dissect in the orbit, and that white thing that you're starting to see there is the tumor, and it's pretty sizable. So I'm at this point jumping out and pushing from laterally through a very, very tiny incision to help deliver this through the nose. Takes a little wrangling here, but very rewarding in just a moment. So we can't use any cautery in the orbit. We can't use anything sharp in the orbit, because if you ding the optic nerve, then the vision is gone. So we're finally getting a clear grasp, and we'll continue to wrangle this out a little bit more. At this point, I made a small incision immediately and pushing a little bit, and we've got several people up the nose, and this thing is going to deliver with a push from lateral and a pull from the nose side. So this saved this woman a shaved head and a long stay in the ICU. She actually went home the same day. Well, she didn't go home, but she went to her hotel. She didn't go back to out of state quite yet. So this is now retrieved and out through the nose. So really cool procedure. Here she is after, before and after. And we wrote a book on that kind of stuff too. So that's all I have, really quick introduction, but I'm happy to answer any of your questions about patients and take care of them if they need my services.
Thank you very much. That was really interesting. We have a minute or two. If anybody online has a question, you can just raise your hand. We'll open your line up. Dr. Goose?
Yeah, thank you for that presentation. I'm sure you're doing nothing like that in the Natick office, but it would be great if, we're always looking for the ability to refer to someone talented like yourself in the suburbs. If you could tell us the extent of the services that you can do in the office.
Sure. So I remove most lesions in the office, and that's really bread and butter for me. A lot of dermatologists don't want to take something off the lid margin or near the punctum, that kind of thing. So almost all biopsies and excisions I do in the office. Most of the post-Mohs reconstructions I do in the office, unless they're extremely large or we have a really anxious patient. I can do upper blepharoplasties in the office. Occasionally an entropion or ectropion repair. The other procedures, I take care of the patients in our Natick office and do their post-operative care in the office, but I take them to Mass A&E for their operative procedures.
You don't do the lower eyelid blepharoplasties in the office, just the uppers?
Yeah, the lowers are a little tricky. It can be done, but it's pretty hard for most patients to tolerate it without a little IV sedation.
Okay.
Are there any questions out there? Well,
I don't see it right now.
Thank you very much. I'm glad you're on the team and offering those services to all of our patients. That's awesome. Sorry to keep you waiting. Some confusion on the lines, but
no worries. I'm just glad we're on time for the rest of your evening. So thank you so much for letting me present.
All right. Well, thank you.
Bye-bye.
Bye-bye. So shifting to Dr. Beeson, we're lucky to have him as a speaker this evening. Dr. Beeson is a family practice physician. His career path moved from, added to, he tended to add things from family practice, then got into physician group, medical group leadership, and ultimately into physician coaching. As a coach, Dr. Beeson works with clinicians to become their best self, find joy in their work, and create transformative results. I love that sentence, and it's really exciting to consider that. He's authored a couple of books. I know we offered Practicing Excellence, and a number of people took us up on it. If anybody wants to get a copy of that, just shoot me or Heather an email, and we'll make sure you get a copy of the book. I know Dr. Beeson spoke at a medical director meeting in my prior company, and it was one of the most talked about presentations we had. So without further ado, I'd like to introduce Dr. Beeson.
Great, thank you, Rich. Can you guys hear me okay?
We can.
Okay. Good, and you can see it okay, full screen?
Yep.
Excellent, excellent. So anyway, Rich, I appreciate the opportunity. Always super passionate about, helping clinicians do things that certainly drive success within the medical group environment, and certainly within the specialty surgical group as well with your team. But I think more importantly, my real passion for this is helping clinicians really find love and joy in this amazing healing profession. Because if you haven't heard, there's some darkness out there. And, my belief, and there's pretty good data that the things that drive true contentment for clinicians are under our full control. Who we are for the patients when we walk in the exam room, who we are for our teammates, and what kind of tribe and family, esprit de corps in this together, serving a higher purpose kind of organizational culture, as well as developing leaders that listen, respond, help, and support, and allow their people to soar as their most precious thing that they have in their organization. We take care of the people first, and then taking care of the patients can follow from that. And to just give you a little background of how I got to be from a full-time family medicine physician to founder of a company now that just coaches clinicians. I sometimes have to pinch myself that that's the case. But for me, it really began about 20 years ago. I finished residency at University of California, San Diego, where I also went to medical school and undergraduate, and was actually born in Sharp Hospital, where I have grown up clinically. Finished residency in 1994 and joined a large multi-specialty group called the Sharp-Steele Medical Group, in a very competitive region, like many of the areas where you are, where we had Scripps Health and Kaiser Permanente and the university and Sharp literally on the same block, competing for the same patients. And our group happened to be in the 6th percentile for patient experience. That's bad. We also had very high physician turnover at 18%, despite living in America's finest city. We had litigation happening between our hospital and our medical group regarding revenue split. And we had 3 consecutive payrolls where we couldn't make payroll. Outside of that, things are going well. And we clearly had to improve as a group. So we made this organizational commitment to become better for our patients, better for our teams, and just a more competitive organization. And I was appointed, tapped on the shoulder, to coach, train, develop, and engage clinicians. I literally got a phone call while I was in with a patient, and my nurse opens the door and says, "Dr. Balfour is on the phone for you." That's our president and medical director. And I walk out to the phone, pick up the phone. He says, "Steve, how would you like to be the physician director for the Sharp experience?" And that was the name of the organizational change effort that we were about to engage in. And I said I would do it without really having any idea as to what I was going to be doing or how I was going to be doing it. But I really became a student of what prompts clinicians to change what they do, to become better at what they do, and to live in accordance with what we thought we were going to be when we joined this profession. And have found the fundamental driver of contentment and happiness in this clinical walk and life in general is living in accordance to the beliefs that we hold most dear. And a lot of clinicians don't necessarily feel like that. So I really became a student of how do we coach, train, and develop clinicians, and what are the things that really work to drive transformative change in terms of how patients see care, and really learned some critical lessons along the way. First of all, coaching and developing skills that are deployed with patients work. We were able to take patient experience from the 6th percentile to the 93rd percentile over the course of about 8 years with about 600 clinicians. But what I also observed subjectively was that the clinicians who were struggling, when you provision simple evidence-derived skills to try with patients, patients would clearly see a difference. We had about a 90% response rate to individual coaching. But what I found was clinicians were had this restoration of enthusiasm, this pride in who they were, this rediscovery of what human connectivity can feel like. And the empowerment of, I can just go do this now. There's no approval, there's no capital, I can just decide who I want to be. And that was really empowering for clinicians. And I had my own experience where I was very average in terms of my patient connectivity. That was not why they picked me to be in this position, but found over time, I was able to deploy simple things in the exam room, and I was able to achieve the 99th percentile in the patient experience for a decade. That's hard to do. But it was just simple things that deeply enriched my life. The movement of patient experience scores is probably the least consequential thing that we do. It's simply a consequence of the behaviors that matter. So what we're going to talk about in this journey is what our goals are. First and foremost, clinicians saying, we're crushing it. And where anybody ever comes in touch with any of our teammates and our brand across this expanding clinical enterprise, we're all going to be uniquely different in terms of who we are, but there's a string of pearls. Man, they always care about me. They always listen to me. They always take my concerns into account, and I'm totally confident in their clinical abilities. And we as clinicians delivering that, we get feedback from patients that are really ultimate sources of pulses of oxytocin and dopamine and serotonin. I mean, it's awesome to be honored with that kind of feedback of the difference that we make. And for patients to say this place is the best, and all the dividends that come from it that we'll cover. And we're aware that before the pandemic, there was a dumpster fire out there in terms of physician burnout. It's in family medicine, primary care, and almost every specialty, it's a real struggle now. And the principal symptoms of burnout are exhaustion, cynicism, depersonalization. Those are tough people to hang around with. I mean, cynicism is immensely contagious. Depersonalization is disconnection from the purpose of the work that we do. I can't imagine living life like that. And in the sense of exhaustion, of I just have nothing left in this tank. And you look at your 401k and you start to do some calculations. Can I bail now? Can I bail now? I mean, that's what was happening before the pandemic. And again, over 50% of clinicians experiencing a constellation of these burnout symptoms and the profound impact it has on our ability to deliver care. And that's why I'm the ambassador, the evangelist, the champion of take care of your people, and they will take care of the patients. We can't just go do patient experience things. We've got to be in a place with leadership governance that sees its people not as our view centers, but as precious people who have hopes, dreams, and ambitions, and we want them to be everything that they always imagined when they joined this healing profession. And again, you can look at data that's frightening, quite frankly, that it's estimated about 1 million American patients lose their clinician every year due to physician suicide. I mean, it's hard to even imagine. I mean, this beautiful profession, the top 2% of earners, virtually no unemployment, societally respected, the endeavor, and what Suzanne had mentioned. I mean, who gets to do that? I mean, that's what we do, the tools that we have, the experience that we've developed, that we can make meaningful clinical difference in the lives of patients, and 20 times a day to make a difference in other ways. We look really good on paper, and what the hell? I mean, how is it that this amazing profession has resulted in this? And where have we gone wrong? And I think with all that we've sacrificed in this journey of becoming clinicians, the saddest thing at the end of our day, week, month, year life is to look over our shoulder and say, well, that was a bad mistake. But the good news is the most enriching experiences of the human condition, of making a difference, building relationships, serving a mission that you believe in, living in accordance with your deepest held beliefs, making a difference and making the world a better place, being useful to others is all. We don't have to wait for CMS to change something to do those things. Those are right there for our choice. So a lot of the message is going to be, we got to decide who we're going to be and let's get after it and go do it. That's an empowering message. In addition to deploying the behaviors at work for patients, and to know that the organizational culture and our ability to compete for staff talent, nursing talent, and the other people that make our clinical workflow is highly dependent upon how we show up. And the experience of patients is most driven by what we do in the exam room. Everybody's a part of the patient experience, but what clinicians do is profoundly important. And again, we're 90% of all clinical activity. We're 80 cents of revenue that comes in of every dollar. We are huge drivers of the patient experience, and our behaviors are immensely contagious. So not only did at the Sharpie Steele Medical Group that our patient experience go from 6th percentile to 93rd percentile, but we also won 4 acclaim awards for clinical excellence. We won the Malcolm Baldrige Award, highest performance award there is in all industries. We went from not making payroll to a 15% operating margin and dropped our attrition from 18% to below 4%. And people go, God, that's by every domain. You just culturally changed. You went from a New York Jet to a Tampa Bay Buck. Sorry to insult anybody out there if you follow the NFL. But anyway, what we found, and people will ask, how did that happen? It was the clinician who serves as leader of the clinical microsystem who leveraged their influence to enroll and engage the people at our elbow. Because it's very hard for Rich to impact everybody at the clinical front line. And it's only at the motor end plate of healthcare where change really matters. And so the clinician buy-in to, I'm going to be a force for good and leverage my influence in my clinical microsystem to raise what people do here by teaching, by recognizing, by encouraging, by modeling, and by sometimes calling people out if need be. But I am going to be an owner of this practice. And not only is that important for the patient experience, but it's also important for just the culture of the organization. And if we look at the drivers, this is mostly primary care data, but the drivers of patient experience are principally driven by what happens in the exam room with us, and access is certainly important, and I know it is with you and your group. Everybody else is single digits. It's not to say that not everybody's critically important and everybody can create moments that render loyalty, but it's really important to know that what we do matters profoundly, not only for us, but check this data out. This is some work we had done with Kaiser. The correlation between how a clinician does and how the rest of the team does. This top circle, which is a calculation of area under the curve, is a plot of all elements of the patient experience minus the clinician. But the clinician teams that are involved with this are those teams whose clinician is in the top quartile. And it's all the other elements of care plotted according to how that clinician does. And in the bottom right is the clinician teams that are in the bottom quartile of patient experience. And what we can see is there's a massive difference between how the clinician goes and how the team does. Is it cause and effect? Is it cross correlate? We don't know exactly. But what we do know is as the clinician go, so goes the team. So, understanding that it's just not us seeing patients, it is us leveraging our influence for the people who look to us for leadership as a capacitator of true organizational brand, patient loyalty, and a reputation in the community where patients feel honored and lucky to be in your care. And where everybody they know, love, and care about has got to come here. I'll drive further and pay more. I'll pay cash to go there because they're amazing. That's the sort of experience and moments we want to be able to create. So the question is, what is the benefit of patient connection to you and your group? and again, there's profound benefits, many of which you know, but it's important to understand that every element of what we consider to be important is at play. And the one that I perhaps feel most passionate about is research that we've done, which is those clinicians that describe the culture where they are, the place where they practice, as truly authentically and legitimately committed to what's best and right for patients. Their probability of burnout is 4x lower than those clinicians who feel like they're in a culture where they are an RVU center. Our hope, dream, and ambition of being a healer was not to generate revenue. Again, there's nothing wrong with money, but I cannot tell you how many orthopedists, I mean, physicians that I know that are making 7 figures that are clinically depressed. Money is not wrong, but it's insufficient in driving human fulfillment. And so it's important to know that the dividend that comes to the group of authentically committing to our non-negotiable simple rule is kindness for every team member and every patient. And that's simply how we roll. And that is our definition in the marketplace. It's what I do every time I knock at the door. It's every conversation I have. It's just simply who we are. And there's good data that allows clinicians to say, I am now being who I know I should be. There's no clinician that finished residency 20 years ago and says, 20 years from now, I'm going to be super cynical, negative, and clinically depressed and on my 3rd marriage. That's my hope for myself. I mean, who wants that? So, the benefits of human connection, patient connectivity is again, it's the retention of patients. And again, there's really compelling AMGA data that there is substantial outward migration by voluntary choice where patients just choose to go elsewhere because it just wasn't that great. And the sentiment that drives that choice is indifference. The sentiment that drives retention are moments that we create that make them say, wow, it's the post-op weekend call where somebody had a complex surgical basal cell removal from the temple or whatever, and the dermatologist calls them on a Saturday and just say, hey, I was thinking of you. How's the wound looking today? How you feeling? Oh, I can't believe it. And then you'll find like 3 or 4 years later, they're saying, God, you remember that time you called me on a Saturday? That was just, you have no idea how many people I told. It's just, God, man, I love you. And it just fills you with pride. And people say, I'm not going to call people on a weekend. Well, try it. It's an amazing experience to provision something good to somebody else. Advocacy in the community. People will become the most powerful marketing tool that there is not a banner, not a website, not clickbait, it is what people say about their experience with you. Participation and recommendations. There was a study that came out in primary care where they rated patient participation for those clinicians in the top quartile of trust. The engagement and the treatment recommendation was about 68% in those clinicians. Those in the bottom quartile of trust, about 15%. So our clinical efficacy is at stake. When patients don't trust us, they're just not going to choose to engage in our treatment recommendation. The engagement of staff, there's strong correlation between the patient, the dedication to what's right and best for patients is a draw to everybody in this healing profession, clinical and non-clinical physicians, medical legal risk reduction. We contend that the provision of these skills in the exam room can eliminate med mal risk. If you look at 97% of medical negligence is not litigated against. So it's not the presence or absence of negligence. It is whether the patient was cared about, listened to, responded to, guided to. There was transparency. That there is an approach and a partnership with patients when harm occurs that can, in almost every circumstance, eliminate you from getting sued. And I think, again, most importantly, what it does for us, it allows us to feel sometimes, particularly in primary care. I know there is primary care here. I mean, there's a lot of the dermatological specialties, but to be a part of something that we can see we're making a difference, and it allows us to be who we thought. And so again, our literature bears that out. In fact, I'll show you the results of a study we had done. This is with Northwell, where the intervention was physician coaching, training, development to better connect with patients. And we found all domain significant improvement in patient connectivity. And the secondary outcome was MASLOC, which is burnout reduction. And what we found was that there was more reduction in burnout than there was improvement in patient experience. So, which is exactly what we had observed. Yes, patients see a difference when we deploy simple evidence-derived behaviors in the exam room, but it's even more beneficial for the clinician. The same thing if you look at kindness literature. People who provision kindness, people who are the recipient of it benefit. The people who give it benefit more. So that's why this falls into the no-brainer category. Again, this is the story of the Sharpey-Steele Medical Group story. It took a long time. And this is Kaiser Permanente. They had 167% net promoter score improvement in just about 6 months' time. This is another group we work with, St. Luke's. They launched physician coaching, training, and development using technology at the beginning of the pandemic, and we're able to get all domain improvement in quantitative patient experience. So ultimately, it is about changing what we do and the actions that we take in the exam room so the patients can see, feel, and experience it. And secondarily, we feel and experience their feedback. And ultimately, change is will and skill. And that's important. That if either one of those are zero, we're not going to change what we do. And what I have found in my 20 years of coaching experience is that I'm going to give you some simple things to use and try in the exam room that you can transform what patients think about you. But what I find to be the sustainer, the accelerator to embedding this in terms of just who we are and how we do our work is when clinicians see and feel the experience of the impact of a particular skill. Let me give you an example. I was coaching a surgeon a couple of years ago, and not everything is about patient experience, it's about other things that advance the culture of the organization. And this clinician, this surgeon was described as low approachability in terms of potential harm or things that may be going wrong with the patient. And we were on a high reliability journey, so low approachability is harm waiting to happen. So I met with a surgeon and I asked the surgeon, I said, do we have good nurses here? And he said, yeah, we've got excellent nurses here. I said, do you ever let them know? And he said to me, I don't thank people for doing their job. So the challenge to him, I said, for our first task, it's going to be recognizing a nurse that does good work. And we're going to touch base in 3 or 4 days. And I want you to be eyes wide open in terms of nurses doing good work, inpatient, outpatient, wherever you are. So he goes, got it, committed to it. And then I want you to tell me what happened when you did that. So the next day, the surgeon was on call, and one of his post-op patients had a burst of atrial fibrillation with a rapid ventricular response and was on the step-down unit post-operatively. And a nurse was taking care of him, and called the hospitalist, called the surgeon, did a cardiac protocol, assessed the patient, communicated with the family, communicated with the patient. She did a fantastic job. So he comes in around the next day, everything's documented, everybody's in the know, there's a plan going forward, all good. And he goes, this is my chance. That was fantastic nursing. So he approaches the nurse and he says to the nurse, I know that I haven't done this ever, but I want to let you know what a fantastic job you did with that patient. Your assessment, your communication, your documentation was just fantastic. And I just want to thank you for the work that you do. And he was just, as he was describing his recognition of this nurse and her response to this recognition, he was looking at the ground. And I could tell that he was struggling a little bit. And as he explained to me her incredible response to that recognition, that he says to me, I'm really disappointed in myself that I've gone 15 years in my career without realizing the power of recognizing people. And he was so moved by this that he wanted to get on the agenda for the next general surgery meeting to become an ambassador for recognition and appreciation of our teammates and the amazing work that they do. And I went to that meeting and I watched him just talk about how important this is. And so that is the learning cycle. It is, I got a skill I can try. I'm going to try it with a patient or a teammate. Look to see what happened. That was good. I'm going to continue to do that. It was so impactful. I'm going to raise my voice and stand up and tell others about my story. And that's what we call the learn, try, share cycle of applied learning. And there are things that are so powerful in terms of what we say and do for patients that it's transformative if everybody could do the same thing. So we're going to talk about that a little bit in terms of what those behaviors are. And so what I want to ask you is you look at your will. There's the skill part, which we're going to talk about, but the will portion is, are these things worth doing? And I can tell you, I was telling Rich before we got on, about 85% of all patients are checking you out online before seeing you. The power they have to choose, the options that they have, and the data that they have access to, good or bad, is just, it's everywhere and it's at their fingertips. And the last time we really checked this data, it was about 35% of patients. And that was 2 years ago. Now it's 85% of patients. It's just what patients do. I'm going to check out and Google my doctor before I go in and decide to see him or her. So there's a lot at stake. And are we good enough? That's a question to ask. And there's compelling evidence that there's a lot of things, and me having coached 800 clinicians, and now I have a coaching app that is supporting 40,000 plus clinicians on coaching and training simple behaviors that drive outcomes. And I can tell you that what we think we do and what we actually do are two different things. I'll give you three very, very quick examples. 3 studies done on the expression of empathy. Okay. That when patients come in with a fear, worry, or concern, we respond to that fear, worry, concern with an empathic response. Oh my God, I can't imagine how tough this must be. 10% of the time, 90% of the time in audio recorded clinical interactions, we miss it totally because we are in the left neocortex of evaluating a clinical problem with our set of questions that we've asked 1,000 times. And empathy is in the limbic system. We sometimes completely miss, and we don't even know that we miss it. The second thing is there's a study done, hopefully it's better now, it was done in 2017, on how frequently patients feel actively engaged in shared decision-making, participatory care, the movement of patient empowerment, that about 5% of all patients surveyed felt like they were actively included in decisions regarding their own health. I mean, we suck. We all get it right on a multiple choice test, right? And there's been 8 studies done on how frequently we interrupt patients. The most current is we interrupt after 11 seconds. So there is indications that there are opportunities for us to become better. And how can we specifically expect to get this right individually and systemically? Because we have to embrace this individually because the group is the sum of its individual parts. And then how do we get those skills into the hands of you? So I'm going to give you the skills. Okay. This is going to be very, very quick. And I'm going to give you all the slides afterwards, but it's really stupid simple. There are 4 emotions that patients must feel as a result of their interaction with us. 4 emotions. Okay. They must feel cared about. They must feel heard, they must feel included, and they must feel confident in us. That's it. Okay. So those emotions, man, I was listened to, I was cared about, they included me and asked me what mattered to me, and they absolutely have it going on. So of those, you can unmic yourself. Which panel of those 4, those emotions are most predictive of patients' loyalty to you and the group? That they felt cared about, heard, confident in, and included. Anybody want to guess which of those 4? Just shout it out.
Except for the speakers, everybody's like permanently muted. We could do a poll through the chat.
All right. So yeah. So put it on the chat and we'll see, because you're muted so put it in the chat, which of those four you think is the most important in driving patient loyalty. All right. Heard, cared about, listened to, cared about, listened to. Okay. There's been a number of studies on this, but the number one is their confidence in you. They're all immensely important and they're all interlinked and codependent, clearly. But the interesting thing about rendering confidence in us is they don't know our clinical ability. They can look at you and they can look at scars and they can look at how you communicate, but they have often no idea what our clinical chops are. So the point being, these are four emotions that we must render for patients to walk out, whether it be on a survey, in the workplace, to their friends and family, to just general advocacy in the marketplace, that drives responses, that drives organizational success. Knowing it's 10 times more expensive to go get new patients than it is to keep the patient that you currently have. Super important for patients to walk out and say, this place is the best. These four emotions drive this. So the question is, what are the behaviors that drive those emotions? So we have to think about, if confidence in us is a really important sentiment that patients walk out with, what are the behaviors that render confidence? We have to know that. And if we were together hanging out in a room, I would ask you, but given that we don't have a ton of time, there are very specific skills that we coach, train, and develop to render patients confidence, particularly important for those fresh out of fellowship and residency who may not have the benefit of age. So they keep getting younger and younger, as we say. And for new clinicians in the group who don't have a longitudinal halo effect. But an example of a skill would be, number one, referencing workup to date. Many of you are getting referrals from primary care physicians. Many are getting referrals from each other. And our ability to link our knowledge and what we're going to be doing to something that the patient understands. I got a really nice note I spoke with Dr. Spees regarding, and to be able to create that linkage. I have seen again and again, and if you look at survey data, one of the greatest frustrations for patients is the clinicians don't appear to talk to each other. And we know why we're going in, but we have to actually reference workup to date specifically, consistently, all the time as we interface with patients. And people say, gosh, how does a group become the best there is in the industry? It is about reliability, because even the really bad ones will do it some of the time. It's about, this is who we are. And as patients come to us, we reference the reason for the referral and the workup to date and my knowledge of it to be able to drive that. And again, I'm Captain Obvious here. You all are going, great, tell me something I don't know. But you would be stunned if you had seen what I've seen in terms of how infrequently clinicians will do this. Second skill, turning the confidence dial, is our ability to explain a medication, for example, the name, purpose, potential side effects, duration of therapy, and clearly what a medication is for. If you look at the data on clinicians in primary and specialty care, the frequency by which we give the name, purpose, duration of therapy, and potential side effects is 1 in 5 times. So we all say, gosh, when we explain a medication, yeah, tell me something that's actually I can do that I'm not already doing. But these are simple things about our ability to explain care to patients. Another one is how we position each other. I'm going to have you see Dr. Johnson. She is one of the best Mohs surgeons in the region. if I had to have this procedure done, or I had a loved one, that's who I'm sending that's who I'm going to. You know, Dr. Johnson's work is done. She would have to actively screw that one up. and again, we don't want to lie. I mean, we want to be able to speak honestly about that, but we have amazing clinicians in your group, and to be able to consistently, in a dedicated fashion, in a reliable fashion, to say, when I make a referral, I position my colleague well to render an opinion and confidence in the patient as they transition from one care provider to another. Another one is how we introduce ourselves. You know, a lot of us, we can mutter our name out, and but when Suzanne, you know, I mean, obviously not everybody has done what she's done, but holy smokes, not in the spirit of arrogance, but in the spirit of, you're in a good place, you're in good hands, we've got you. And just to relieve, you know, sometimes it's a little nerve-wracking to meet a clinician for the very first time, just to put your mind at ease. I specialize in procedures just like this. I've done tens of thousands over my career. I've had specialty training and this, that, or the other, and find a thumbnail that you're comfortable with. And it's done, again, for the spirit of relieving patients' fear, worry, and anxiety, and building confidence. And so again, simple things about referencing work up to date, our ability to explain care, explain medications, to use teach back and verification of understanding, to position colleagues well, to leverage what we've done. I used to do tons of sigmoidoscopies as a primary care physician. When I did tons of that in my training, and I'm 56 now, but when I started practice, I was 29, and I looked young. And these patients would come in not knowing me, and they would look at me all gowned up and having done the prep and go, "Oh God, are you doing this?" And I had to learn about how to present myself to relieve their worry and fear and to build confidence. And again, it's transitioning from ad hoc when I feel like it to, this is what we do, and this is how we roll, and this is how we render patients' confidence. So I'm going to wrap things up here because I know we've just got a few minutes left. For patients to feel cared about, I mean, I mean, obviously we care about patients because we're in healthcare, but unless patients feel in a palpable, witnessable way that we're signaling that we care about you, they're going to walk out and go, "Yeah, I wasn't feeling it." So what do we do to assure that connectivity arises and manifests, so the patients walk out and not only do they say, "I'm really confident by all the things that drove confidence," but I really felt cared about. And one of them certainly is empathy. I mean, our ability to have eyes wide open regarding what they're going through, the copays on their Humira for their, you know, for their psoriatic skin condition. I mean, it's whatever it may be. And the thing that is most important, and the trait that amazing clinicians have, is this incredible spirit of curiosity. They want to know about the people that they take care of. You know, what do they love to do, and who they are, and what they do for a living. And through curiosity, we're able to discover hardships and challenges and circumstances that allow us to say, "Oh man, that's it." When your youngest goes off to college and you're an empty nester, it's hard. I know. We went through the same thing. You know, we'll be in this together. You know, it's sad. And but that only manifests with curiosity and learning about the people that you take care of. To be able to say at the end of a clinical encounter, you know, "We're going to be with you every step of the way." God, what a great way. They may forget everything, that they had to wait 3 weeks to see you, they had to wait 20 minutes to see you, but you go knee to knee with them. "We're going to be with you every step of the way." Oh, man, you're the best. That's a moment. That's a moment that renders, you know, an experience, because we tend to forget things over time. We remember moments. And so there are things that we can do that render and turn the dial, that signal that we really do care about you. And one of my favorite techniques is just to say to the patient, "You know, we care about how you do after you go home. I want to make sure you have a place to call, a number to call, and a way to get a hold of us should anything arise. I'm really confident that you're going to do fine, but if there's any questions or issues or concerns, here's a number to call. We'll get back with you within a couple of hours. So, you know, those are signals. This team's got my back. And then skills to listen to. I mean, again, you know, paraphrasing the history. So what I hear you say is, and to allow the patient to finish their story. And I mean, again, I shared with you the interruption process. And my favorite question to ask to really verify that patients feel heard is to ask the patients, what about all of this worries you the most? Because that's what you think they're worried about, and what they're actually worried about may be two entirely different things. And it's presumptuous for us to extrapolate a chief complaint to their greatest fear and worry. And to be able to ask the patient, what about all that you're going through right now worries you the most? You will discover extraordinary things that will turn the lights on to allow you to dig down to really what they're worried about, and to be able to address that with a great degree of specificity, as opposed to totally missing the boat and being too afraid to be able to say what really worries them. And for patients to feel included. We got an amazing team here, and you're captain of this ship. And we're going to make care decisions regarding you together. I'm going to give you some guidance and advice based upon my experience and training. But you're part of this deal. You know, we're really still in the collect symptoms, do biopsies, make recommendations, and book the surgical time slot. I mean, we're still in that mode to a certain extent. So those are things, you know, just an example of some of the specific behaviors that can render pretty transformative change and take no more time. In the spirit of learning skills and trying skills and sharing your story, I always tell people that in order for us to transform our organization and how patients see us, everybody has to be doing this at all times. And the greatest diffuser of that from, you know, you're all 61 of you are going to get, you know, just a little inoculum of a few skills. But it's the clinicians who stand up and say, hey, I tried saying to the patient, what about all this worries you the most? Let me tell you my story. Then somebody else is going to do it. Somebody else is going to stand up. And that's the learning contagion that allows the diffusion of skills in creating and diffusing the skills across a clinical enterprise. So to finish, I always encourage clinicians really to decide, you know, who you want to be. This question I always ask clinicians when I begin coaching: tell me about the kind of clinician you want to be. What do you envision for yourself? It's not my choice, it's theirs. And then, you know, we help take action to be who they want to be. And again, living in accordance with your deepest held beliefs is where happiness resides. When we feel as though fitness is important and taking care of yourself is important, but you've gained 40 pounds and eating Doritos and drinking Budweiser every night, you're living out of accordance of your beliefs, and it creates remorse and sadness and guilt and depression. And I know this is wrong, but I just can't stop. So, but finding who we are and who we want to be, and just simply building the skills to allow that to manifest, and feeling what it's like to be able to make a difference as this constant cycle of learning and applying and doing it on your own and doing it together as a group. And I know that there is a profound challenge in healthcare today. That's Viktor Frankl is my one of my most admired survivors. Was a psychiatrist in a survival at Auschwitz, and you know, he said, as the quote said, Jackie, that's a great comment, and we'll take that in some Q&A. That between stimulus and response in this thing called life is a space, and in that space we have a chance to choose our response, and in that response lies our freedom and our strength. So medicine has almost an unlimited number of substrates right now. that we could crap on. A lot of things that are troubling in medicine now. But the essence of this healing profession, of making a difference in the lives of patients, being collaborative with a sense of family and tribe, with your teammates going together, leveraging your influence to lift the people beside you to become their best, and leaders, and all of us are leaders of our clinical microsystems, in helping people become the best version of themselves, is a really worthy walk in this clinical life and life in general. So with that, those are a quick bolus of my words of wisdom as to why this is immensely important for us, the brand, the patients we serve. It is a driver of financial success in every sense of the word. It's who doesn't want to be a part of a champion culture. And again, it's fun to be a Charger now, and it's fun to be a Tampa Bay Buck. And so with that, Rich, I'll pass back to you, and happy to field any questions or curiosities, but we'll allow you to get on with your meeting.
Awesome. Thank you very much. Great presentation. You know, you hit the nail on the head. There's a lot of challenges, and it's nice to hear some ways that we can take some of that back and create some positivity and spread that. It certainly aligns with our core values at AP Durham. So appreciate that. I wouldn't change a thing in your presentation other than you could have said New England Patriots, but that's, you know, for another day. So with that, maybe
I had to modify the presentation from last year's to this year's. No. Or 2 years ago, I should say.
Heather, why don't we open it up and see if there's any questions out there? You want to remind folks how to ask a question?
Sure. You should be able to, if you go hover over the bottom of your screen, you should be able to pull up a Q&A, and you should be able to type right into that.
This is Sam Goose. I have a question. Do you have any tips in terms of clinicians providing an apology to a patient and when that's appropriate?
Yes, there's pretty good literature now on this. There's and again, I would love to hear sort of what the clinical context is. But there's the I'm Sorry campaign, which was at the University of Kentucky at Lexington, has demonstrated that transparency and apology when a harm event occurs, and gathering and navigating with the patient and using their experience to fuel improvement, literally eliminated 100% of med mal events, because patients want to know that their harm created a benefit to others, and that's sort of a, you know, part of the I'm sorry messaging. But typically, I'm sorry is reserved for when there's a clear breach of standard of care, or there was just falling short of what your standards are. A patient called in for a biopsy result and nobody ever called the patient back until the patient called for the 5th time. You know, we're clearly we dropped the ball, but even that, here's how we're going to take this experience and make our team better. And we apologize for what you've been through, because I can only imagine how frustrating that was. But here's how we're using this experience to make our team better for others who come in with circumstances like yours. It's not admitting, I mean, you can talk to your attorney friends, but the patient response to I'm sorry's are overwhelmingly positive when it's appropriate and framed up to an improvement solution.
Are there any questions out there?
I don't have any questions in the Q&A. Another way is to click on raise your hand. And as a last resort, you're welcome to text me and I'm happy to speak your question.
I know we got a couple of comments that the book was a good read. So If anybody didn't get it, again, text me or Heather or send me an email. We'll make sure you get a copy.
Yeah, and Jackie had posted an interesting comment that millennials, which are real decision-making demographic, have about 30% confidence in their clinicians. And you know, there is a number of different confounding variables there. Number one being the generational disposition and their probability of embracing clinicians as a trusted source of information. But I would also say, is it what we do as clinicians? There's I was heard, I was included, I was cared about, I was confident in. The sum of those four emotions are trust. So those four dials generate trust, and whether we're able to turn those to be able to generate trust.
So a couple questions came in through the chat line and the Q&A. One was, can you discuss being sincere and what that means?
Oh, being sincere. You know, part of you know, faking authenticity is is hard to do. When we, with the skill of empathy, when we coach and train in a deep dive with clinicians, our directive is help envision what it must be like for that patient in that moment, and allow that to help you act in accordance with that. And the two elements of emotion, the two elements of empathy are authenticity of our response and support for them, because people can sniff out fake when it comes to empathy. And the second is the words that we use. Oh, your dog died. Too bad. I mean, it's all in the voice, pace, and expression of the words that we use that convey and signal authenticity. And those words come across authentically and sincerely when we mean it. And again, depersonalization that occurs from clinicians who are experiencing burnout is a real barrier to that.
Another question is out there. What holds providers back from patient connectivity?
The fear that it's going to take too long. There's, I would say probably the most common reason now is clinicians are just clinically overwhelmed with workload, administrative burden, and task-related activity, and it separates them from the channel of human connectivity, the simple actions that drive human connectivity in that encounter. That not only creates moments for patients to walk out and become your advocate, but it also fuels restoration for the clinician. So the idea of reducing administrative burden, having things like scribes, you know, and improving operational experience of the clinician has been shown to be able to have profound impact on clinicians' ability to dedicate themselves to connectivity. Another piece of research we had done in a survey of over 500 clinicians, when we found that physicians who felt as though the administrative burden was not being addressed in their organizations, their connectivity to patients was reduced 78%. So that's why we often say, what are the things that we can get out of your way so you can be the clinician that you want to be? And without that, and we just say, go connect with the patients, here's some skills to do it, you may get marginal uptake and sometimes no uptake at all, because there's no sense that nobody's taking care of me and my life is overwhelmed with work burden. Therefore, my ability to connect need to the patients and do the things that we know work is really hampered. So we could dive into that in much more detail, but that's often a barrier to connectivity.
Great. One last question just came through. A lovely talk. Do you currently have a clinical practice and you have you personally experienced burnout or moral injury?
I'm gonna spend 2 minutes to tell you a very quick story, and I know that we're over time because a lot of the reason I do what I do is my own experience. I still see patients more on a concierge basis and pretty clinically active in that front with all my credentialing and licensing. Had a full-time clinical practice for about 20 years, but I founded a company that coaches and trains clinicians that is, I told Rich, is 1.5 FTEs for me. It's a very, very busy time in my life. But let me just share the story with you, and then we'll close with this. When I joined medicine, my measure of success was diagnose, treat, and cure disease. And it was compelling enough for me to sacrifice everything that we sacrifice financially, socially. Between 20 and 30 is basically deleted from our lives, and we get into clinical practice. And I found that when I arrived in clinical practice, between self-limited disease and chronic disease and functional disease, terminal disease, my ability to make a difference as I had defined my success that prompted me to choose this profession in the first place was a very small portion of the time. And I thought to myself, I just made a terrible mistake. I sacrificed my youth for this. I have accrued debt for this. This is not what I want of my life. And I've made a terrible, terrible, terrible mistake in choosing becoming a physician. And I couldn't imagine myself going another 6 months, let alone another 15, 20 years. And it was at that moment in that window that I was asked to lead this endeavor. And I thought it was a divine intervention to try something different. And I began coaching clinicians and learning myself. And I remember at that time in my life, I had this kid come in to see me, 15-year-old kid that came in to see me. And he came in with his mom, came with a sore throat, clearly a viral pharyngitis, no adenopathy, no exudate, no fever. And I did my clinical evaluation in 3 or 4 minutes. I swabbed his throat as though they felt as though I'd done something. And then I asked him, I said, so where did you go to high school? And he said that he mumbled, staring at the exam room floor, that he went to Poway High School, which is my alma mater. So we had that in common. Then I asked him, what do you want to be when you grow up? And he didn't say anything, stared at the ground, his mother sitting to his right, super awkward pause. She finally kicked him and said, tell him what you want to do. And he said, mumbling to the ground, I want to become a doctor. And I thought to myself, you got the personality for it. So I told him about getting into medical school, the MCAT, the short coat, the long coat, and the passage. And we spoke for maybe 1 minute. I come into clinic the next day and I get a phone call from the boy's mom. And I pick up the phone and this mom says, Dr. Beeson, I want to thank you for something. I want to thank you for rescuing my son. And she told me about her son, who was this bright, young, ambitious kid who had fallen into this abyss of depression. And they had tried everything. Psychologists, psychiatrists, SSRIs, they were shattered that they had lost their boy. And she says to me, for the first time in almost 3 years, he's talking about his future. Viral pharyngitis. And I realized in that moment that medicine occasionally gets to diagnose, treat, and cure disease. But it is this amazing instrument to change lives. And all of this was in front of us with each and every patient that we see. And it's the greatest gift to us is to be of service to them and to be the clinician that we aspire to be and that we sacrificed everything for. And that was my story that really began this entire journey. And that's kind of what got me here, to be totally honest. So anyway, that's my burnout story. It's pretty raw.
Thank you again. That was a great story to end on, very motivating, and it really points to how we impact people knowingly or unknowingly every day. So really appreciate you taking the time today and joining us and sharing with us your experience and all that you know. It was great to see you again.
Great. Thanks, Rich. I'm out. Thanks, you guys.
All right.
Thanks, everybody.
Take care. We'll talk to you soon.